This is we have chosen a topic of diabetic ketoacidosis management challenges. We face challenges in diagnosing, challenges in practicing and treatment, and of course the follow. And what are the pitfalls we do in common day-to-day practice, and what are the best practices by the guideline? That's what I'm going to do in another maybe 20 to 30 minutes. The diabetic ketoacidosis remains a common, preventable, and potentially fatal, as already mentioned by our chairperson, potentially fatal acute complication of diabetes. In India, DKA remains the leading cause of ICU admission even among the younger and elderly individuals. Despite clear guidelines, the mistakes do occur, but mortality is less than 1% in experienced centers, whereas 5 to 10% in resource limited setting, elderly, and patients with comorbids. These are not the system related problem. These are system related and knowledge gap issues, but not the individual failure. If the patient is going for a complication by treatment or for following treatment, it is not the individual failure, it is a system failure, because you need to do a lot of monitoring, and maybe the system should be on a protocol. The core concept of DKA, diabetic ketoacidosis, is not primarily a hyperglycemia problem. It is a combination of absolute or relative insulin deficiency counteracted by excess. Because of the excess sugar, there is increased counteractive hormone. That is another problem, because increased cortisol, increased catecholamines, increased growth hormone, increased there is another glucagon. So many catecholamines are increasing, and severe intravascular volume depletion. It is not just hyperglycemia. Severe intravascular volume depletion due to dehydration, severe dehydration, and total body potassium deficit, and also the most importantly the metabolic acidosis component. So the glucose is a marker, it is not a killer of diabetic ketoacidosis. What are the diagnosis challenges, especially after the usage of the SGLT inhibitors? We come across euglycemic DKA, and why this challenges is that the patient having only mild to moderate elevation blood sugar, maybe 210, 220, or to less than 250, and we will have acidosis due to vomiting and sepsis, lactic acidosis. We will miss it. We won't make a diagnosis of DKA, because in general, if you have a DKA, your blood sugar should be more than 250. If anything less than 250, 200, 210, generally we don't suspect DKA. And if especially when a patient comes with vomiting and fever, sepsis, we always think of metabolic and lactic acidosis than diabetic ketoacidosis. So these are the areas where we miss, and the missed ketones if the urine is tested. Sometimes, if you do, you suspect DKA in such situations where the sugar is only 210 and there is an acidosis, we do urine ketone may be negative. But what is the best practice is, when you suspect in such a situation, you measure blood beta hydroxybutyrate and calculate the anion gap. Anion gap is always elevated in diabetic ketoacidosis and always increase the blood levels of beta hydroxybutyrate. This is the best practice. So we find the challenges in diagnosis. And regarding the severity of diagnosis, DKA is not the glucose level. The blood sugar is high 100, 500, 600. Oh, severe DKA. The acetone is positive. Blood sugar is 500. Oh, severe case. It is not a severe determined by the glucose. The severity is defined by the acidosis, where the pH is less than 7 and bicarbonate is less than 10. Patient is tuberous or comatose. These are the severe. It is not the high blood sugar. Sometimes when a blood sugar is high, we'll think that is a severe DKA, and blood sugar is low, it's a little less severe. It is not that, it's only acidosis. The common percent, another important area you need to, or we commonly miss, is that we find diabetic ketosis, blood sugar is high, more than 350, 250, urine acetone positive, 2 plus, 3 plus, 4 plus, and patient be tachypneic, dyspnea, hypotension, all DKA, perfect DKA presentation. But the precipitating factor is the infection, UTI, pneumonia. Unless you address these precipitating factors, however you treat, with the difficulties, you won't be able to get a good outcome. So we miss infections. Sometimes myocardial infarction, strokes can present the decay. So we manage DKA, but you'll miss MI or stroke unless you look for it. And similarly, sometimes new onset diabetes you would not have expected as a decay at all, because first time is not a diabetic and it comes with the DKA, we will miss it. And of course, either now we are using SGLT inhibitors where blood sugar is slightly elevated, but still you can develop DKA. The best practice is to do DKA and look for the triggering factors. Another most common mistakes what you do is, well, blood sugar is high and severe dehydration. We give wrong fluids. Wrong fluids means we have several fluids we have. We have normal saline, we have half normal saline, we have glucose, we have 10% glucose, we have oral. Which fluid to give for how long to how much? That is very important. You just because the DKA, you cannot be rushing fluid from 10 to 20 ml per kg like that. Keep pushing, the pulmonary land up in a pulmonary edema, especially in a patient in a heart failure, especially in CKD, you end up in a complication. The too much of insulin, blood sugar is high, 500, 600, you give full bolus dose and followed by infusion, suddenly they will go for hypoglycemia. Ignoring the potassium, we always look into the glucose, we always look into ketone, we always look into the blood pressure, but what we ignore is commonly the potassium. Unless your potassium is more than 3.5, in spite of your high sugar, we should withhold the insulin and correct the potassium, then that's a guideline. And not only that, and forgetting the comorbid physiology, like heart failure. A particular patient would have diabetic ketoacidosis presentation, but he might be having heart failure with reduced ejection fraction. He might be having CKD for longer duration. He might be a pregnant woman. So we cannot be treating like guideline 10 to 20 ml per kg per hour. Similarly, give high dose insulin, suddenly go for a complication. To avoid these mistakes, clinical assessment, hydration status, look for comorbidities, and align the treatment as per the guideline. You always go by the guideline. You have a wonderful guideline available to practice. And what is a basic test, what is required, what is the basic calculations, only ABG. ABG, blood sugar, electrolytes. And of course, calculation you have to do, anion gap, serum osmolality, corrected sodium. These are some calculation. So we need not to have high-fi investigations or very costly files to manage the DKA. What you need is only basic urine sugar, blood sugar, electrolyte, and if at all ABG. That's all, nothing else. And this is an essential tool in the management of DKA. And regarding the anion gap, why should you calculate the anion gap? Anion gap is a marker of acidosis. Even before you get the ABG report, just get the electrolyte report, electrolyte value, calculate the anion gap. Sodium minus chloride plus bicarbonate. If normally it is 8 to 12 milliequivalents per liter. If it is high, in a setting of blood sugar as high, 250, and a high anion gap, instead of 12, it is 14 or 16, 18, and that is the confirmation of high anion gap acidosis, possibly diabetic ketoacidosis. Even before you get ABG report, just based on the blood sugar and electrolytes, you calculate this anion gap and you make sure it is a diabetic ketosis you are dealing with. So the infusion of insulin infusion should continue until anion gap closes. So anion gap is necessary to start insulin, because high anion gap with a high sugar, with the ketone, you make a diagnosis of DKA, you start insulin based on this. And also the insulin infusion should be continued until anion gap closes, the blood glucose normalizes, not the blood glucose normalizes. So anion gap confirms ketosis, anion gap helps to start insulin, anion gap helps to stop insulin, because the closure of anion gap is the best marker of ketoacidosis, not just blood sugar is coming down. Then calculating osmolality. Again, the calculation osmolality is a simple calculation. 2 into sodium plus glucose by 80 plus urea by 6. This is a simple calculation. What is the useful of this? The higher osmolality indicates the marked dehydration. You cannot go intracellularly and find out the dehydration of the cells, but you calculate the osmolality If it is normally is 275 to 295, if it is more than 300, high osmolar. So it draws the water from the cells and is more severe the osmolality, more severe the dehydration, more amount of fluids required for this patient. And also the cerebral risk, there is cerebral edema. That means if you give insulin, rapidly correct blood sugar, you correct more than 3 milliosmoles per kg per hour, suddenly go for cerebral edema. So it helps to predict the severity of dehydration. It helps to control or prevent cerebral edema by not rapidly correcting the blood sugar within a few hours. Then you do corrected sodium. What is corrected sodium? Corrected sodium is equal to measured sodium plus for every 100 milligram percent of glucose, more than 100 milligram percent, there is a fall in potassium, there is fall in sodium by one. There is actually, sorry for this, is actually glucose minus 100. It is not, sorry, it is a typing mistake. Glucose minus 100 by 100. So that means for every 100 milligram increase, this fall in serum sodium by 1.6 milligram milliequivalent percent. That is a corrected sodium. So you have to correct your corrected sodium. You calculate why this is important. It will guide what fluid choice to be given after the fluid bolus. Now you give a fluid bolus, you give normal saline, 0.9% normal saline, irrespective of the osmolality. Whereas after the continuing fluid, we make 1 or 2 hours later, what fluid to be continued? Whether normal saline has to be continued or you switch over to half normal saline based on the corrected sodium. If corrected sodium is low or normal, you continue normal saline, 0.9%. If corrected is high or normal, you switch over to half normal saline. So what type of fluid you should give, that based on the corrected sodium, not by the volume status. And the fluid management, where the common mistakes occur. So that's the reason why the American Diabetic Association emphasizes, the principle emphasize, restore intravascular volume first, then insulin later. Even though blood sugar is high, even though ketone is strongly positive, 4+, acidosis points less than maybe 7 or 7.1. First you restore the intravascular volume, then you go for the insulin. Even before the insulin, the fluid comes, fluids alone drop the blood glucose by 50 to 100 milligram percent. So why should you start fluid even before insulin in a patient with DK with a high blood sugar, high osmolar state? Because it dilutes the glucose. Not only that, it increases the perfusion of the kidney, thereby kidney excrete glucose, and the volume status improves, the patient improves. Thereby, just to fluid giving fluid, it brings down the blood sugar by 50 to 100 milligram percent, even before insulin. Then you go a stepwise approach. The step 1 approach, step 1 is the initial resuscitation. Initial resuscitation, irrespective of the type of fluid, type of DKA, you have to give 0.9% normal saline, 10 to 20 ml. If the hypertension, if it is not an hypertension mild, you have to lessen the fluid, maybe 5 to 10 ml per kg first 2 hours. And especially in elderly and heart failure, you have to reduce the dose. And for every bolus dose, you have to check to prevent or to monitor for the pulmonary edema, whatever the complications. The step 2 is ongoing fluid. Once you are given a bolus fluid of 10 to 15, 20 ml per kg for 1 to 2 hours, then go for an ongoing fluid. What ongoing fluid will you choose? After the first 2 to 3 hours, you have to choose fluid. That's why we already alluded to calculate the corrected sodium. If corrected sodium is high, you have to go half normal saline. If corrected sodium is normal or low, you go normal saline. So that's how you go. And step 3, when glucose comes down below 200 or 250, shift to 5% dextrose plus half normal saline. So this commonly we ignore, but it's very important. Nowadays we are alert, we are doing so. So you have to shift, you have to add 5% dextrose, and with the normal, that is a half normal saline to continue. That's a step 3. So step 1, start IV fluid. Step 2, what IV fluid be continued. Step 3, you have to add 5% dextrose, and the purpose of adding 5% dextrose is you have to continue insulin infusion till the acetone become negative. If you keep on continuing insulin, you go for hypoglycemia. To prevent hypoglycemia, you have to give glucose. That is the reason why we should start glucose. There is the glucose infusion whether 5% dextrose or 10%, whatever. So because you have to prevent hypoglycemia, because this person need to continue insulin for the prevention of ketosis. And it emphasizes, the fluid therapy emphasizes most resident fear and fear of insulin delay. Suppose by this time all these things takes, electrolytes takes, and calculation, all these things maybe take 1 hour time. 1 hour time, blood sugar is 500, ketone is positive, acidosis is there. Then we were apprehensive, why have not started insulin, so on. So we should not fear of insulin, we should fear of fluid more than the insulin. And the fluid only is proper. That's the initial management. Especially even in edematous, say even for patient with the heart failure, because of the intravascular volume depleted, you may have to give first bolus dose as usual. Probably when you give, you have to check monitoring for the pulmonary edema. But even though heart failure, even though CKD, the first hour fluid should be as usual, because there is aiding with the intravascular volume depletion due to hyperglycemia there. But it's a mild DKA, not this much. If it's a severe DKA, severe acidosis, the first hour, 2 hour fluid should be given without any alteration. So the common mistakes here is overload, especially elderly in heart failure, and continuing normal saline despite sodium is rise because we don't calculate the corrected sodium, and stopping insulin as soon as glucose falls. That's another problem, because if you stop insulin, again a recurrence of the DKA or resistance of DKA, so it won't get resolved at all until you give the insulin until it clears. So forgetting the dextrose solution. These are the common problem. So the insulin, American Diabetic Association preferred approach is, and before you insulin, you check the potassium. Potassium is more than 3.5, you give insulin. Actually, now the current guideline is more than 3.5. If it is less than 3.5, please avoid potassium, because the moment you give insulin, even before the glucose drops, the potassium drops, because within few seconds, within few minutes of insulin, the potassium entry into a cell is started. Only 22 few minutes later only the glucose starts coming down. So the severe hypokalemia leads to like no arrhythmias, and the paralysis may be there. So please avoid giving insulin if the potassium is less than 3.3 millimoles. And the current guideline is they don't recommend the bolus dose. The reason is when you give bolus dose, suddenly bring down the blood sugar, bring down the osmolality more than 3 milliosmoles in few hours, it might lead to cerebedema. Hence, is not recommended as it is, but still you can give the bolus dose if any facility is not available to start infusion immediately, or any delay in starting infusion due to so many other the practical difficulties. In those situations, you can give bolus dose of 0.1 unit per kg start dose, followed by the infusion dose of 0.1 unit per kg. So that you can start. And of course, and the target fall per hour, the first few hours should be not more than 50 to 75 milligram percent. So the faster fall is equal to cerebedema risk. More faster fall, more chance of cerebedema. So you have to be careful there. So when glucose is less than 200, and you have to decrease the dose of insulin from 0.1 ml unit per kg to 0.02 unit per kg, and continue it till the anion gap closes, bicarbonate more than 18, pH more than 7.3. Till such time you have to continue small dose of insulin like 0.02 unit per kg per hour. And if glucose goes down, you go again continue with the glucose infusion. So the faster glucose fall, that doesn't mean it's a better care. You have to be very careful in bringing down the blood sugar faster. The cerebedema risk already mentioned. It is very common in children, and you should not bring down the osmolality more than 3 milliosmoles in few hours. Regarding insulin therapy, the pitfalls or the bolus dose, rapid osmolar shift, and the best practice is to continue infusion and no bolus is required. Continue infusion till anion gap closes and acidosis resolves. So the two parameters to look into before you stop insulin in these individuals. And regarding the potassium, ideally you target the potassium to 4 to 5 milliosmol per liter, because The potassium is a silent killer. The golden rule is serum potassium is misleading in decay. That means even though the serum potassium 4 to 5, but the total body potassium deficit will be there. It is because of acidosis, the intracellular potassium moved from the cell into the vascular system. That doesn't mean the high potassium in the body. So it is a misleading in decay. So total body is always depleted. Hence, the ADA, the potassium algorithm, what it says, potassium replacement should be commences as soon as urinary output and serum potassium is documented. So when a patient with DKA acidosis, and even though acidosis is severe, even though the blood sugar is high, you have to document potassium. Only then you start the potassium. And if it's less than 3.5, you correct the hypoglycemia by 10 to 20 milligrams per hour. And once it's corrected, you continue it. And if you reaches 3.5 to 5 milliequivalents, then you give 5 ml for each pint. That is 10 to 20 milliequivalents for each liter. You give till you maintain the target is 4 to 5 milliequivalents. If it's more than 5, no potassium. So you have to maintain less than 5. Regarding the bicarbonate, this another one area which is a confusing area. You want to say the house agents or the postgraduates is very fond of giving acidosis, you give acidosis, give bicarbonate. What the ADA recommendation? The ADA, American Diabetic Association, persistent treatment unchanged, but often violated, because it should be given only the pH is less than 7. Why? The routine use of bicarbonate worsens hypoglycemia. Patients already having potassium deficit of anywhere between 200 to 3 milliosmoles in DKA patient. So if we give bicarbonate, further it can cause hypokalemia. 1. 2, they delay the ketone clearance. How it delay? You give bicarb, it delay the ketone clearance. Ketone clearance get prolonged. The reason is the acidosis. Acidosis is the one stimulus for insulin secretion. You give bicarb, you correct the acidosis to a normal pH, and the insulin secretion will decrease. In DKA, no insulin secretion or deprived of insulin secretion. Now you decrease. Not only this, the paradoxical intracellular acidosis, your bicarbonate is absorbed, it is converted into carbonic acid. The carbonic acid is again converted into water and CO2. CO2 one which diffuses faster into the cell and makes the intracellular acidosis. So you may correct the intravascular acidosis, but intracellular acidosis will be worsened by your bicarbonate, and that impact the insulin action, where the insulin secretion is decreased, and further you are impairing the insulin action by intracellular acidosis. Thereby, there is no mortality benefit. In fact, it worsens the mortality by bicarbonate, but it can be given if it is less than pH is less than 7, or severe shock or severe hyperkalemia we can give. So now how to give bicarbonate? Just to take a 50 milliequivalents, that is 1 milliequivalent equal to 1 ml. So 50 ml of 7.4% soda bicarb, dissolve in 200 ml of sterile water. You add 5 milliequivalents. 5 milliequivalents is 5 ml. So 10 ml is 1 ampule, that is 20 milliequivalents. You give 5 ml of potassium chloride and is administered the first 2 hours until the this pH is more than 7. You give this correction. Once pH reaches 7, stop bicarb. Very rarely used. Regarding the phosphate and magnesium, this is another area which commonly we miss, and there is a phosphate depletion, there is a magnesium depletion. They may present with muscle weakness, respiratory failure. You are treated properly, you have brought down the blood sugar under control with your standard protocol, you are given adequate IV fluid, you have corrected the potassium, still patient is paralyzed, unable to get up, unable to recover fully. The reason is not only the glucose and acidosis or the insulin, potassium, that may be weakness due to hypophosphatemia and magnesemia. So you have to look for it. If it is severe hypomagnesemia or hypophosphatemia, you have to correct it to prevent cardiac arrest. And yet another problem what we face is transition. Once you have corrected the DKA by our fluids, insulin, potassium, phosphate, and of course, if at all bicarbonate correction, everything is over, and the ketones also become negative. So now you have to switch over to the IV insulin, to the subcutaneous insulin. But the common is if you stop insulin, IV insulin, and wait for it, and you start separate insulin, later it might, the development of the rebound DKA will occur. So we have to start basal insulin, like glargine or degludec, even before you are stopping the insulin, maybe 1 to 2 hours before stopping insulin infusion, you start glargine, because it will start acting slowly and it may take 2 hours. And once it starts acting, then you can stop insulin. Thereby, the rebound ketosis may not be there. So resolution of DKA is mainly by the 3 parameters. Now you have completely done. You have done your job, close monitoring. You brought on everything is under control. You have to check for glucose. Glucose should be less than 200. Bicarbonate previously it was less than 10. Now it's more than 18. The pH previously it was 7.1 or 7.3. Then anion gap previously 17. Now close. So that it is a recovery. But sometimes ketone may be positive at this stage. The urine ketone are useful in this stage. It is useless. Your parameter for recovery is only all 4 parameters, not the urine ketones. Urine ketone will be there for maybe few days, sometimes weeks also, because of, so all depends on how much of lipolysis has taken place and how much of insulin deficit was there. And there are few challenges also we face in special situations. And also, no, all the DKA managements are not same for everyone. So in elderly individuals, the risk of fluid overload will be there. Even though the guideline says 10 to 20 ml per kg, don't give 10 ml per kg, because elderly, you won't tolerate in spite of dehydration. Probably slightly lesser dose you can give. In pregnancy, volume overload, and also that the lower, even the pregnancy, one other problem with the pregnancy is even the lower sugar. You need not wait for 250 blood sugar to make a diagnosis or suspect diagnosis of DKA. Even the 200, 210, 215, they will develop DKA, classical DKA, because of lower the threshold for them. And so you have to be suspicious. And as DKA in the patient with the CKD, potassium, already potassium will be high in CKD, and further potassium will be high, so you have to be very careful. And also in the patient with the SGLT inhibitors, their glucose may be normal, but still they have DKA. So once you are suspect. So what are the golden rules in a special situation is like a DKA when special situation is that make an early diagnosis, suspect it, confirm by acidosis, confirm by anion gap. That's the early diagnosis. Correct the precipitating factors. Look for a precipitating factor. Why a patient has developed DKA? Is not so many. He's having diabetes of 10 years, 20 years, type 1 diabetes. Why now presentation? Something has precipitated. Maybe the infection or some stress or steroid, some drugs that you have to look for. And fluid, first choice. The insulin is only next. Potassium before insulin. Close monitoring is hourly is very important. That is a stage for success. If you really want to be a successful consultant practitioner, close monitoring of the patient definitely will lead to a wonderful outcome. So do not rush corrections. So what is the best practice? The best practice is wonderful, the algorithm given by ADA 2020-26. It was released last month. Wonderful guide. It covered entirely. That is, if you follow this, no one will miss the management. Okay, so you only 3 parts: IV fluids, insulin, potassium. When you give, when to give IV fluid, how much to give? To give IV fluid, to determine hydration status clinically, hypotension, tachycardia, dehydration, severe dehydration, severe volume depletion, mild, no tachycardia or mild tachycardia, not severe, mild dehydration. It is a mild volume hypovolemia. And patients already heart failure, who is a percent DKA positive, so it's a volume origin. So you have to see whether which is dominated. If it is severe hypovolemia, especially with the tachycardia and hypotension, you give normal saline. That is 0.9% normal saline. You give 10 to 20 ml per hour, 1 to 2 hours, 3 hours, till the BP improves. That's it. Once it improves, right, then you correct. The bolus dose is over in 1 or 2 hours, then you calculate the total deficit, how much has happened. Usually, 7 to 10, that is the potassium level, and 100 ml per kg, 50 to 100 ml per kg will be the deficit. You have to calculate it. 50% of the calculation. Usually it comes around 5 to 7 liters. 50% you give in 8 to 12 hours. That you have to give. Once it is corrected, you go for glucose. If glucose is less than 250, as we already mentioned, you go 5% dextrose or 10% dextrose. Once it is goes less, you check for electrolyte whether the potassium, sodium, everything is corrected. Now go. This is regarding the IF-rate. Regarding insulin, now very nicely divided into mild DKA, moderate DKA, severe DKA, and hyperglycemic hyperosmosis (HHS). In mild DKA, previously a regimen was not given as a subcutaneous insulin. In this 2020-26, it is given that subcutaneous insulin is allowed. What subcutaneous insulin? Insulin analog, that is rapid acting analog is allowed. If the only DKA, mild, not much of dehydration, no volume disturbance, that is hemodynamic disturbance, only ketone is positive, you have to give insulin. You give rapid acting insulin 0.1 unit per kg, and every hourly you can give. And if you want to give every 2 hourly, you give 0.2 unit per kg, every 2 hourly you can give. So that is what the recommendation is. And if it is a moderate DKA, you start with the IV insulin as it is. You consider 0.1 unit per kg short-acting insulin, IV infusion. Bolus may be given. If there any delay in starting IV infusion, you can give bolus, otherwise not required. And the same thing shall be continued. And similarly, and you have to maintain the blood sugar less than 250. And if it or DKA, you have to keep the blood sugar less than 200. If hyperosmolar state is anywhere between 200 to 250, not too low. Again, there is a confusion with the alterations will be there. Regarding the potassium, you check the potassium. If it's less than 203, 3.5, you correct with 10 to 20 milliequivalents per hour. You correction until potassium reaches more than 3.5. If it more than, but whenever you give IV large boluses of potassium, especially in a state where less than 3.5, you have to give central line and give the insulin. Once it is corrected, probably you can go by, if made in 3.5 to 5, you give simple correction. You go 5 to 20 milligrams per liter. That means that is 5 ml in each pint. You give till you maintain the serum potassium of 4 to 5. If it is more than 5, better avoid insulin. That is the recommendation. So regarding the management of this DKA, I already mentioned. You recovered. Recovery is planned by the pH more than 7.3 and the bicarbonate more than 18, and the capillary blood glucose more than less than 200. So that's the thing. And the bicarbonate should be given only when the pH is less than 7. So I go the two cases, simple case scenarios. It is a 25-year-old female. Is a type 1 diabetes, 20 weeks of gestation. Is a pregnant woman, 28 weeks. She was admitted with fever 3 days, abdominal vomiting, breathlessness 1 day. And because of the fever, she missed the dose of insulin. And patient, when he got admitted, drowsy, dehydrated, tachypneic, dyspneic, and BP was 80 by 60, pulse rate 127, tachycardic, respiratory is increased 140 per minute, saturation maintained, blood sugar was 456, ABG was taken immediately suspected decay, so no second opinion about it, and pH was 1.1, and bicarbonate was 15, and severe metabolic acidosis, urine acetone was 4+. Potassium was 5.6, and sodium was 128, and calculate the anion gap, and urea creatinine was elevated, 56 urea, creatinine 2.3, anion gap was 17 instead of 8 to 12 normal, it is 17 elevated. So high anion gap metabolic acidosis. When calculate the osmolality 290, it is not very much elevated, it's not hyperosmolar state. And corrected sodium, even though the calculated this measured sodium is 128, we calculate the corrected sodium, it was 134, it's not hypoglycemic. But the total count was 11,400. The urine plenty of pulses. So possibly this lady woman, the pregnant woman, developed UTI. The UTI triggered the fever. I mean, UTI triggered this sepsis-like thing, and she could not take food. So because she could not take food, she did not take insulin. That matter DKA and sepsis, and because of the severe dehydration, she developed AKI. So the immediate priorities in this particular patient is not correcting one by one. Correct that is hypovolemia, and correcting the insulin, correcting the sodium, not one by one. Here the problem is pregnant women. Every minute is important. The fetal mortality is going to be high if you correct slowly. So you do simultaneously correction. Do not correct one by one. Airway breathing circulation, this patient, because the patient is still patient response is oriented but drowsy. So we continue high fluid optimized. Insulin was started. potassium monitored, identify the infection, aggressively start infection, and continuous. And the continuous monitoring is very important. The continuous maternal and fetal monitoring is very, very important to save the life of the mother and the fetus. So why DKA is dangerous in pregnancy? DKA in non-pregnant women is not that much problem, whereas in pregnancy it complicates. The reason is that the DKA can occur even with low sugar level. You need not have 350, 400, 500, 600. Even with the 200, 220, 20 or 30, it can precipitate DKA. One. Then rapid progression to complication, very common because already volume overloaded. So 50% of the volume, plasma volume increases, 30% of the RBC increases in a pregnant woman. So on top of it, all these complications, very difficult. So progression to the severe. And fetal mortality is 10 to 35% in a pregnant woman. And mortality, maternal acidosis is very common. If at all maternal acidosis, there's a decrease the uteroplacental perfusion and worsen the insulin resistance, thereby increase the placental hormone insulin resistance. So because of these difficult problems, the managing pregnancy decay is very, very challenging and difficult. So this particular patient, we as per the protocol as given by the ADA, we have given all the fluids are given, fluid resuscitated, improved intravascular volume, and corrected the sodium, and what fluid to be continued. Yes, normal saline continue, and the blood sugar once is come down, you have to give dextrose. It was continued as per the guideline, and the clearance of ketone, but avoid hypoglycemia during ketosis, because the pregnant woman develops severe hypoglycemia. Once they develop hypoglycemia, fetal arrhythmia, fetal hypoglycemia is very common. Intermittent death is very common. Be careful. One, acidosis is difficult. Acidosis also, the outcome of the fetus is bad, and also hypoglycemia, so fetal outcome is bad. So you have to be careful with this. So continue insulin till acidosis resolves, because acidosis also worsen the outcome. Then insulin potassium, yes, it has to be given. It was given. Patient was close, and the potassium was monitored. It was monitored very well. In this particular case, even though the pH is pH is 7.1, so obviously it does not require bicarbonate. So no bicarbonate at all. If indication for bicarbonate, I had already mentioned, pH less than 7, life-threatening hyperkalemia, and severe hemodynamic instability like cardiac arrest or severe hypotension or shock. It's not improved with your vasopressor, cyanotrope. Probably you can add bicarbonate, otherwise not indication. Especially in pregnancy, giving bicarbonate is dangerous because the bicarbonate is a paradoxical fetal acidosis, CNS acidosis. We give bicarbonate, as already alluded, that it decreases the pH of the mother, whereas it increases the intracellular pH of the brain in the fetus. This is called paradoxical acidosis, and the fetal acidosis that will worsen the outcome. So better avoid bicarbonate in pregnancy. And of course, this particular patient, as the infection was a trigger, I put pyelonephritis, but if CT scan was not suggest for pyelonephritis. But anyway, started with the higher antibiotic, piperacillin, tazobactam, ceftriaxone, patient improved clinically. And the message is that DKA will not resolve unless the precipitating factor is treated. That is the message. So if you ignore this, just take it lightly, patient won't get the adequate improvement, and mortality behind. So the monitoring is very important. That the monitoring is a success to the treatment is that hourly CBG, vitals, urine output, because of pregnant women, you should not take a chance even a bit. And every 2 hourly you do ABG, BBG, electrolytes, ketones, and fetal monitoring is very, very essential. And continuous fetal heart rate monitoring, even after stabilization, is important to avoid emergency delivery. Avoid emergency delivery unless it is an obstetric indication. So DKA is not an indication for emergency delivery. You manage DKA by regular protocols and with careful monitoring. But if at all you take our LSCS, it is only obstetric. It is not a metabolic problem. So the resolution as patient improved, and there is overlap of insulin base were given. And the decay in pregnancy, the one thing important is that decay in pregnancy is medical. Not only is a decay in pregnancy, decay is a medical problem, but decay in pregnancy is a medical and obstetric emergency. So fluid first, insulin continuous, potassium vigilantly. neither hyperkalemia nor hypokalemia. So treat the triggers aggressively for a better outcome. Never stop insulin early. Continue insulin. Mother stabilizations saves the fetus. So now I'll go to rapidly to the second case scenario. It is a 54-year-old female, type 1 diabetes of type 2 diabetes of 15 years, CAD, that is coronary heart disease, heart failure, the religious ejection fraction 33%. Patient present with acute dyspnea, PND orthopnea, 1-day duration. Patient was conscious oriented, tachypneic dyspneic, BP was low, 90-60, pulse rate 124, respiratory increase, saturation very low, CBG was 202, and urinary stone 2 plus, and then ABG was taken 1.2, acidosis, and bicarbonate, CO2 is low, it's got respiratory, probably secondary respiratory alkalosis, and the NT-proBNP was elevated 3020, and sodium was low. And this scenario, we have calculated the serum osmolality. It is not very much, it is low osmolality. Anion gap is not elevated, low no anion gap, and the corrected sodium is 124. What is the primary diagnosis? So even though this patient is presented with acidosis, even though patient presented with the DKA, that is ketone positivity, even though hypertension and breathlessness, the diagnosis is acute decompensated heart failure with the cardiogenic pulmonary edema, because history of PND orthopnea is there. Saturation is very low, and it is only ketosis, stress ketosis, and metabolic acidosis with the respiratory alkalosis. So it is not a typical DKA. Now the question is this DKA? Yes, we go by the guideline. No and no. Let us apply a diagnostic criteria. So because even though we suspected is a DKA, it is not DKA, it is a heart failure, we go with the criteria. What are the criteria? To say criteria, DKA. Sugar should be more than 250, year 212, 250. pH should be less than 7.3, year 7.2 is there. Bicarbonate should be less than 1.8, year is 13. And urine acidity should be 3 plus, minimum. It is only 2 plus. Anion gap should be elevated, that is not elevated. So the anion gap is not elevated. Urine only 2 plus. Bicarbonate is only, and pH is only, the two parameters, other things are all against the DKA. It is only a ketosis, acidosis. It is not a diabetic ketoacidosis because of this, and it is due to the severe cardiogenic shock, hypertension that resulted in lactic acidosis, and that is probably the most likely a ketosis. Lactic acidosis due to hypoxia and decreased cardiac. It is not DKA. The why it is important is if you manage as a DKA by your fluid, it worsen the heart failure, it will worsen the hypoglycemic status, and hypokalemia will be lessened. So you have to be very careful. So best management for this particular patient is, even though acetone positive, even though sugar elevated, even the acidosis, the best treatment for this patient is immediate oxygen, non-invasive ventilation, BiPAP preferred, loop diuretics, low dose, continuous, vasopressors, especially noradrenaline, and treat the acute heart failure. Do not give aggressive fluid. Do not start insulin infusion for DKA. What are the lessons learned? Not every acidosis with the ketone is diabetic ketoacidosis. This particular patient, second case, diabetic is a ketone positive, acidosis is there. But not every acidosis with the ketone positive is DKA. DKA means it has to have it won the criteria. In heart failure, because of hypoxia, low cardiac output causes lactic acidosis and stress ketosis. The treatment, the hemodynamics is more important than keto and sugar. So the correct approach is in such situations, when you are confronted with the situations where the blood sugar is not very much elevated, more than 250, less than 200, you don't go by the urine acetone, you go with the blood beta-hydroxybutyric acid level. If it is elevated, yes, suspected, or maybe more of DKA rather than the urine acetone positivity. So the clinical clues for the postgraduates are hypertension, tachycardia indicates a severe volume depletion. One can clinically tell severe volume depletion just by measuring the blood pressure and pulse rate. That's all. The elevated urea creatinine, the lab report, indicates again the severe intravascular volume depletion. So that's also volume depletion. That is also volume depletion. When you put Riles tube in a patient with DKA, all patients with DKA acidosis, and high sugar, ketone positive. Don't put Rylstib and put Rylstib aspiration, continuous monitoring are not required. Rylstib is to prevent aspiration of gastric canal if the patient is vomiting or having altered sensorium or comatose. Otherwise, there is no need for Rylstib. The severity of decay is not directly proportional to blood sugar as already to. Severity decay depends on the severity of the acidosis, not the glucose. And of course, the beta-hydroxy beta is very, very essential. Is preferred over urine testing with nitroprusside testing to assess the amount of the bicarbonate, that is ketone, in the body. The urine will assess only the acetoacetate and the acetone, which is not sufficient to make a diagnosis of the ketosis, diabetic ketoacidosis. Friends, the take-home messages are: DKA is a physiological emergency. It is not just hyperglycemia. It's an emergency combined, consists of so many things. Fluid saves lives even before insulin. Potassium errors, either hyperkalemia or hypokalemia, kills silently. Insulin should be precise according to the patient condition and blood sugar level, not aggressive. The mortality, and when you see the comorbids, modify the strategy, but not the principle. Patient having heart disease, heart failure, CKD, pregnancy, cancer disease, it will not modify the principles. It modify only strategies. What to give first, what to give next. But the principles are same. Friends, the guidelines treat the diseases, the wisdom treat the patient who has the disease. Thank you very much for patience.
We have some questions.
Yeah, please.
Sir, first question is, can oral be used as a fluid of choice in DKA?
Absolutely, because the first fluid should be a normal saline. The reason is first 2 hours, irrespective of the status. The reason is that the sodium, every 7.2 10 milliequivalents per kg of sodium loss in a DKA. So that there will be excess sodium loss will be there. The first resuscitation fluid should be a 0.9% saline. The subsequently, you have to calculate the corrected sodium. If corrected sodium is normal, you can give ringer lactate. If corrected sodium is high, you give half normal saline. If corrected sodium is still low, you can still continue normal, 0.9% saline. So again, depends on the corrected sodium. Yes, absolutely indicated. You can give after the bolus dose of maybe 1 to 2 hours, 3 hours, you can shift over to ringer lactate if the corrected sodium is normal. Otherwise, if it is a high, you have to give normal saline, off normal saline. If corrected sodium is high, you have to give off normal saline. So it's all depends on corrected sodium. That's why I edited, but I just put one line on ringer lactate, and I did not highlight much on the ringer lactate, because once they started giving ringer lactate everything, and ringer lactate again, it is maybe appropriate if you calculate this normal sodium, that is corrected sodium. Otherwise, it might acidosis will worsen sometimes.
Okay. So,
after correcting the hydration, if you want, you can give. But before correcting the hydration, if you give ringer lactate, it will worsen the acidosis.
Yes,
it will worsen
lactic acid better because of dehydration. Lactic acidosis is
Yeah.
better to worsen.
It will worsen the lactic acidosis as well as acidosis.
Yes.
Better avoid.
Yes. So the next question is, in spite of potassium correction twice, still the potassium remains at 2.8 and CBG is 400. Shall we give insulin infusion or still need to correct potassium? Or any other?
It's very, very important. That's what, in any given time of DKA, the potassium loss is in the body is anywhere from 200 to 300 milliequivalents. So we have to give 300 milliequivalent for a DKA patient, total requirement. But you correct slowly because it might cause arrhythmias. So that means the total body potassium you are not corrected. You have to keep correcting. But only when the potassium is more than 3.5, you continue insulin dose, IV insulin. Otherwise, you should not give, because so much of potassium deficit there in the body, you have to correct. You already started with before correction. You have to correct the potassium, only then start insulin. And when you give insulin, the potassium further will go inside. The first action of insulin is to make the entry of potassium inside the cell rather than the lowering glucose. So further it will worsen. So thereby, then you stop insulin, you do correction, you 20 milligrams, 10 to 20 milligrams, you take a maximum dose, 20 milligrams per hour, you give like that. There is 1 ampere power infusion like that. You correct it, you check up to 200 milliequivalents to 300 milliequivalents. And once, even after that, the potassium comes down, probably this is not due to DKA, it may be due to some other metabolic problem. You check for a magnesium. Sometimes if you give magnesium, it will correct potassium because magnesium, potassium goes together. If you correct magnesium, you give 2 grams of magnesium sulfate as infusion or by the IM, it will improve the potassium. So you check for, that's why you have to see magnesium correction, magnesium deficiency, phosphorus deficiency. When potassium is not getting corrected, you give adequate dose of potassium up to 200 milliequivalents. In spite of that is not getting corrected, you look into the other causes, you look for the magnesium deficiency and phosphate deficiency, you correct it, probably it gets settled. Most of the time it gets settled.
Thank you, sir.
Yes.
Thank you for the elaborate discussion, sir.
Oh, thank you very much. It's a pleasure.
Sir.
Anytime. Yeah. That's all the questions, sir. Only 2 questions, sir.
Yes, sir.
Okay, doctor. Thank you very much. Thank you, Ranjit, for inviting and making me to talk on this. It's very useful. Thank you for me also. Thank you very much.
Thank you, sir.
Thank you, sir. Chairperson, sir.
Thank you, Paranthaman. Thank you.
Yeah, I'm very glad that you have been there. And I know you love this topic and you've been treating in ICU or ICU. Take care means you will be there. You make 2, 3 visits, 4 visits, even before you leave, you 3, 4 times you come to IMCU and give instruction, check the monitoring and give instruction to the PGs and staff nurse also. I've seen that. And that's why I was very happy that you come here and I shared your knowledge. Thank you very much, sir.